Okay, so endotracheal tubes we covered yesterday, and I tried to put a little synopsis in the email. I talked about dead space. Any When you talk about the machine, when you talk about the breathing system and the endotracheal tubes, those are all mechanical pieces. Okay, so any part of that that's too big or too far from the patient increases dead space or the space between oxygen to the alveoli. Okay, so what you're doing is trying to minimize, you can't take it away. There's always going to be dead space, but we can make it shorter. Now, anatomical dead space, say for example, you give a drug that's a bronchodilator, okay, and the bronchioles dilate. Well, when they increase in size, that naturally increases anatomical dead space. So the majority of the dead space that we try to manage is on the mechanical side by choosing the proper tubing, the proper bag, the proper endotracheal tube, making sure it's not too long. But once you get into the patient, then we're getting into what do the drugs have any effect on the diameter of the airways? And that's when I'm talking about anatomical dead space is space inside the patient. The only thing we can do is be careful of what drugs the patient is on. But if you have a patient with asthma and they're on a bronchodilator, they need that medication. So I may need to breathe more for my patient. There's ways I can help the patient because I can't change the fact that their airways are dilated. So as long as you understand what the difference is between anatomical dead space and mechanical dead space. Now, masks, if you're going to use a mask on a patient, that automatically you are giving either oxygen or oxygen and anesthetic to your patient. So they are a cone and they come in different sizes. Now they can be used, you can mask induce a patient. Instead of giving it propofol or Ket-Val, you could pre-med and put a mask and have them inhale. The problem is, if you remember back to stage 2, which is excitement, the injectable agents will push a patient from stage 1 to stage 3 rapidly. When an animal is inhaling gas, they're going to travel through that excitement phase. And they may hang out. So I've had patients with a mask and they're struggling and they're fighting and the gas smells, they don't like the smell. I can't do anything about that. But it can be a very stressful situation to mask induce. Now, the other way that you guys might use these masks is just to give a patient oxygen. So sometimes we hook this up and we do what's called like pre-oxygenate the patient. In an ideal world, I would give a patient oxygen for 5 minutes prior to induction for every patient. Time-wise, doesn't always happen. Does every patient need it? Potentially not. Brachycephalics, it's very good. I like to pre-oxygenate. It's kind of like you're giving them a reserve. They are going to maybe go apneic. They might be hard to intubate. If you give them 5 minutes of oxygen, you're preloading them. So there's a benefit. And you might do that with a mask. Now, there are different sizes. So here's a picture. And they got these really little ones, and then they've got big ones. We used this big one once. This was kind of funny. I was on emergency at Circle City and we saw exotics, and this lady runs in with a hamster and she's like, it's basically kind of looks like it's dead, but it had a heartbeat. And we put it under that cone. So we just laid it on a table, put the cone over it and gave it oxygen. And then we put a little bit of Karo syrup, some sugar, because the doctor's like, maybe it's hypoglycemic. It popped up under the little mask and it started like grooming itself. So we put some little like seeds underneath and it started like eating. But we used this big mask like a little mini oxygen chamber. So you can get creative with these masks. Now they all come with a rubber gasket around that's going to fit around the muzzle. So you can see on this stuffed animal that it does create a seal. It's not perfect. If you are masking a patient and some of that gas could escape and you're being exposed. Now, I will tell you, and I always say this, there's some men in here, but the majority of you guys are female. If you think you are pregnant, and a lot of people don't want to tell people right away that I might be pregnant, or, you know, ISO and SIBO are fairly safe for the fetus, but in those beginning stages, the old anesthetics could cause spontaneous abortion in women. So we had to be really careful. ISO and SIBO are better, but people could also pass out. So it can be a risk if you're pregnant. You shouldn't really be around mask induction or induction at all, really, if you're pregnant. I mean, I will say my anesthesiologist knew I was pregnant before the majority of my family because my job was anesthesia every day. So I was like, dude, I'm pregnant. And he was like, get off the floor. And then I had to wear a mask. They ordered me a gas mask and it filtered out the anesthetic. I still was cautious, but when you use a mask, there's always going to be a little bit of escape gas. And let me give you something food for thought. So a lot of people at work, it's not a good idea if you're in veterinary medicine to hide that you're pregnant, because working around x-rays and working around anesthesia are risky for the unborn baby. So you usually have to fess up to your employer. My boss tried to keep it a secret, but when I started not being around for inductions, it didn't take people long to figure out, is Christine pregnant? People kind of figured it out that, Christine keeps disappearing. It's not on purpose, but, yes, and litter boxes. Thank you, Kirsten, for bringing that up too. But let me give you an idea. When you are exposed to anesthetic gas, you are exposed at 5 parts per million. It only takes 5 parts per million. You don't smell anesthetic gas till it's about 50 parts per million. So it has to be at 10 times your exposure before you smell it. So sometimes people mask induce and they do this and they go, well, I don't smell any gas. It doesn't necessarily mean you're not exposed. It may just be not at a high, but you're exposed at 5 parts. You don't smell it till it's 50 parts. So I don't want you to use that as your gauge. As long as I don't smell it, I'm fine. Okay. So I'm sorry, I'm harping, but if I'm on the topic of masks, I just mention that because some people think mask induction is the safest way to go. It's very stressful for the patient. A little tip, if you are just giving oxygen to an animal, if you just have to, I can confirm for my surgery. Yeah, Caleb, some of the newer anesthetics, well, I will tell you, ISO and SIBO smell. In desflurane or what they use in people, it may not smell, or what they did is they started you at a low enough level where you didn't smell it as much. But when you have to mask a dog or a cat, you have to run a higher percentage of gas. It definitely has an odor. But I think in people, they can mask that a little bit. But what I want to tell you is if you want to just give oxygen to an animal, you can take this black rubber thing off, and then you can just put the cone so the animal doesn't feel constricted, because some animals don't like their muzzle constricted and they fight. Now, if you're giving anesthetic, you need that black gasket. But if you're just using oxygen, you can take that off and put it back on. They come off and on, okay? So masks, different sizes are used to deliver inhalants for mask induction or to give oxygen pre or post recovery. So if I ask you what a mask is for, that's what it's for. Chamber inductions are sometimes called cat box induction. If they say I'm going to box a cat down, this is what they mean. Let me show you the picture first. So they're usually about the size of an aquarium, like a fish aquarium. They do make mini ones for exotics. So they do make like little chambers, but a standard clinic usually has at least one of these somewhere. The advantage to this is you've got it. Now this black tubing is the breathing system. So basically one tube is giving inhalant and oxygen, ISO and oxygen. The other hose is letting the gases escape, the exhaled gases. So one is fresh gas flow, one is exhaled gases. And then they hook up to the machine. So normally what you do is you can put the cat in here and then you box them down. I'm going to tell you it's very violent. I've tried to find some videos online and there's not a good one that shows beginning to end. But I've had cats bang their head against the chamber because they go through excitement phase. And sometimes they drool. I've had cats pee and poop in here, and then they're rolling around in it, which is a lot of fun because then when you go to scoop them out, you're like, fantastic. I will tell you, the only time I'm a fan of this is if you have an extremely aggressive cat. We had a really bad cat for radiation. She was devil spawn, evil, and the owner knew it. This cat needed 22 radiation treatments. I was like, oh my gosh, I got to anesthetize this cat 22 times. So what we would do, we would take this box in the room. The owner would take the cat out of the carrier, put it in the box. We would close the lid. She'd be hissing and spitting and hitting the glass. We'd knock her out. She'd go completely asleep in the chamber. Then we'd take her out, intubate her when she was asleep. And then when it was time to wake her up, she would, they got demonized on YouTube. I'm telling you, this cat, I don't, whatever, she was mean. Her name was Tinkerbell. Thought that was funny. Anyway, when she was half awake, we would get the carrier from the owner. We'd put her in the carrier. When she started growling, we'd take her to the owner, and we did that 22 times. But you really could not. I could have probably wrapped her in a blanket and gave her an injection, but we were doing a very quick radiation, so she didn't really need pre-meds and all that. I just needed her asleep. The disadvantage that I want you to put on here is it's very feral patients, vicious. I have used a chamber on a Shih Tzu. If the dog can fit in here, you can use it, but it's primarily for cats or exotics. Now exotics, if you were going to put a rabbit in here, if it's a small cat or a rabbit, sometimes I put towels in here because it kind of takes up the space. And also hopefully prevents them from banging their head sometimes. But I'm going to tell you that you cannot monitor. I mean, I can watch the patient breathe, but I can't feel a heart rate. I can't check its gum color. Sometimes they slide their mouth up the side and they're like, and I can kind of look at their gums and be like, okay, they're pink. But you don't want to open the box because then you let out all the gas and then you have to rebuild it up. So I don't open the box until they're asleep. So really, you're only observing their movement when they're breathing. So it's hard to monitor, but there is a lot of, this is stressful. And when you open that lid, I'm like, everybody take a deep breath. Usually I would have someone take the box and put it in like the corner of the room or take it into another room for it to air out. Because when you open it, you're going to get a blast of all that anesthetic. And some people are sensitive to that smell. So you have to be cautious for your exposure, stress on the patient. So that's, if I ask you why you use a chamber and what are the disadvantages: exposure to personnel, stress on the patient, lack of monitoring. Okay, that's what I don't like about the chambers. Now, for the machine itself is basically, there's a lot of notes under here. Machines can be very expensive. One of the most expensive parts of the machine is the vaporizer. The vaporizers are not cheap. So, a lot of the parts can be like hodgepodge. Basically, what I want to put a note on here, this first machine, A, is a large animal machine, and B is a small animal machine. You can use a small animal machine for 300 pounds and under. 300 pounds. So you could put a calf or a foal. Most at Purdue, the large animal hospital, we had small animal machines. So if you had like a goat, a small pig, a calf, a foal, as long as they were under 300 pounds, you could use a small animal machine. Now, anything over 300 pounds uses a large animal machine. It is the same parts. It is the same flow. It is exactly the same as the small animal machine. It's just bigger. So do know that weight range. Small animal, 300 pounds and under. Large animal, 300 and over. And I have anesthetized a 220-pound Mastiff. So dogs can get pretty big. I think it took like 5 of us to lift the patient on the table. That was a lot of fun. The job of the machine is to deliver oxygen and a volatile anesthetic controlled. So it's going to go through parts. So we're going to go through each part and what is its job. So I'm going to show you two. Well, I'll get to it. The other thing I want to say is, Miranda, if they're at 300 pounds, then it's going to depend on their condition of three. If they're a lean 300 pounds, I probably use the large machine. But say they're an overweight 300 pounds and they're supposed to weigh like 250, then I'd probably use the small one. Does that make sense? It's going to kind of depend on your patient. Like, how are they breathing? If they're having a hard time breathing, you want to go with the small machine. If they're a very healthy 300 pounds, I'm probably going to go with the large machine. Okay. And yeah, I would ask the doctor, but it kind of, like I said, the large machine is big. They have to breathe pretty well to move the air through all those parts. So that's the way I think about it. How well can my patient ventilate through that machine? If I want to make it easier on them, I'm going to use the small animal machine. But if I think they're fairly healthy and they've got good respiratory drive, then I can probably get away with the big machine. And you can always switch. Like if you are on a large machine, it's not convenient and easy, but you could potentially make the switch if you had to. Okay, so let's start. Oh, the one thing I was going to mention, and I tell students this all the time, the machines that we have at school, almost everything is labeled, and they're fairly new machines. So it's like flush valve, vaporizer, outlet, everything's nicely labeled for you. When you go to your practice for externship, job shadow, take a job as an assistant, you might have a very different looking machine. I always tell students day one, or show up a half an hour early to your shift and familiarize yourself with that machine. There is a way to hook up a breathing system to a bag and make it act like a patient. So you can play with the machine without having a patient on it. Get used to the dials, trace your flow. You do not want to be in a situation where you have to put a patient down on a machine and you don't know how to work the machine. That's a very bad position to be in. So it is on you. Either someone in that practice needs to show it to you, explain how it's used, because I will tell you, machines are intimidating and some of them are really old. The parts are all the same. The flow, I don't care what it looks like. I don't care what configuration, all of the parts and the flow should be the same. You just have to familiarize yourself with what they are. So I always say day one of if they're expecting you to do anesthesia or to assist, you need to play with that machine before you have a patient on it. Okay? That's on you. A good anesthetist is prepared. Again, you don't want to walk in there and be like, yeah, I got this. And then you're flipping around, and someone's got to jump in and save your butt. Make sure you know your equipment. Okay, so basically, all I want you to know Number one is the carrier gas is oxygen. We do not use nitrous oxide as a carrier gas. There is a very, very slim possibility your machine will have a nitrous tank and an oxygen tank. Because remember, I said if you run nitrous, usually the flow meters are by each other. But for the purpose of our lecture, oxygen is your carrier gas. Oxygen carries anesthetic to your patient. You have to have an inhalant and an anesthetic, so you have to have a vaporizer. So you have to have an oxygen source. You have to have a vaporizer. It's going to mix the gases, mixes the oxygen and the anesthetic, and then you have to have a way for the exhaled gases to leave the patient. Because when they exhale, they don't want to re-inhale that. They're exhaling CO2. When an animal exhales, it's a mixture of exhaled gases, which is CO2. There's going to be some inhalant that they didn't use. They're going to be also exhaling used inhalant. And then there's going to be a little bit of oxygen. So it's kind of like a mixture. And we have to have a way for that to leave. And it has to not be under pressure. We have to make sure that they can move air back and forth. So there is some type of scavenging system that has to be attached to it. So basically, you're going to have a compressed gas, which is oxygen. There's two types of vaporizers that you can have. They are called precision. Precision is what you're going to use the most of. That's what ISO and SIVO use, is a precision vaporizer. If you work out in the middle of nowhere, Mr. I'm 50 years old, want to be Dr. Paul guy, you might use a non-precision vaporizer. I guess that's what SIPES used. It'd be very rare because you're really not supposed to use ISO and SIVO in a non-precision vaporizer, but there's always going to be that rogue vet out there that just can't let go. But you know, it's on you day one to figure out what kind of machine and what kind of vaporizer you have in your practice. Okay, so I'll explain the difference. You have to have breathing systems. Now, I'm going to talk about the breathing systems. We'll talk about how you pick them next term, and then we have to have a scavenging system. Now, when you look at these pictures, they look kind of discombobulated. They've basically taken a machine. This is like a schematic. They've kind of like if you were looking at like a diagram or a blueprint of the building, they kind of spread things out, and it's like, here's a water line, here's a closet, here's a door. This is taking the machine and kind of spreading it out. So I want you to follow this through me. Okay. So you're always going to start, and this is like blood flow. Think of it this way. Think of it this way. If you are an oxygen molecule traveling through the anesthetic machine, where do you go? So you're going to pretend you're an oxygen molecule, and you're going to go through every part. So oxygen is going to start, and I'm going to explain these in depth, but just follow me for right now. Oxygen starts in a tank, okay? You turn it on in the morning. Your little oxygen, now there's a pressure gauge. That tells you how much pressure is in your tank. So it's going to go from the oxygen tank, the pressure gauge. Now, when you turn on a tank, it's kind of like you turn on your car. How much gas do you have? Do you have a full tank, a half tank, a quarter tank? That's what the tank pressure gauge tells you, how much oxygen is in the tank. Now, there is a pressure reducing valve right here. On most of the machines, this is built in to the line and you don't even see it. Some machines you see it. It kind of depends on the machine. But what this does, when you turn on a tank, when you turn on an oxygen tank, it's under pressure. If you did not have a pressure reducing valve, it would blow up your anesthetic machine. How many of you have heard if an oxygen tank falls over, it becomes like a missile? It will actually bust through a cement wall. Have you guys heard that before? When you guys are using oxygen tanks in surgery, they are in a cabinet and they are chained. That is OSHA. You will get fried on an OSHA you have an inspection and the oxygen is not secured, that's I mean, it could break a leg. It could break someone's leg. It could crush a limb. I'm not even joking. So a tank, an oxygen tank, most compressed gases are under pressure. Now, the pressure reducing valve reduces the flow to the machine so it's at a safe pressure. Okay, so it has to go from a tank. How much pressure is in your tank? Now let's slow the pressure down, reduce that pressure, reducing valve, and then somewhere there is a gauge that tells you how much pressure is in your line. Yes, exactly, Michaela. So, tank pressure gauge, people get these gauges confused. Tank pressure gauge, how much oxygen is in your tank, then we're going to reduce it, and then we're going to tell you how much pressure is in your line. Normal line pressure should not be above 50 psi. Now I'm going to get into that in the lecture, but let me just type it here. And oxygen pressure is measured in psi. Okay, you cannot have a pressure above 50 psi to your machine. Too high. Okay, so this pressure, this line pressure gauge, if you were to check it, should say 50 psi. Okay, so now you've turned it on, it goes through here, then there is a little, do you see there's like a fork here? For right now, we're going to follow this straight line and we're going to go to the flow meter. The flow meter, if you've ever seen an anesthetic machine, there's a strip like a gauge, and it has a little dial, and there's a ball that floats, and this is set in liters. One thing you need to know for the test, if I say what is the flow meter set in, the flow meter is set in liters. When you turn that on, oxygen is going to go into the inlet of the vaporizer. If I point to that spot, that's only oxygen. When you turn on, where's my air? When you turn on the vaporizer, the oxygen is going to go in here. It's going to pick up some ISO, and then it's going to come to the outlet of the vaporizer. Now at the outlet, you have oxygen and anesthetic to go to your patient. If the vaporizer is off, say you've turned it off, then oxygen goes through the vaporizer, but it does not pick up anesthetic. It still goes through the vaporizer. Liters. The flow meter is liters. It's set in liters. Standard flow to a patient is 1 liter. Liter per minute. Thank you. Liter per minute. So if you have it at 1 liter, if you have it on the 1, it's 1 liter per minute flow. Okay, so now I turn on the flow meter. It goes in the vaporizer. I have the vaporizer turned on. That oxygen is going to pick up a buddy. It's like a little car. Come on, ISO, let's go. Then you've got the breathing system. Don't follow this top arrow. Don't look at this non-rebreather right now. Look at this bottom one. It's going to go into your patient, and it says fresh gas inlet. That is the breathing system going into your patient. So now it goes through a valve called an inhalation valve. When the animal inhales, this little valve is going to open up. The animal is going to inhale. This is the breathing tube. And you see this Y piece right here is where you hook up the endotracheal tube. Remember I said there was a patient end and a machine end? This is where the endotracheal tube hooks up. Okay? Now here, your patient would be right here. So your patient inhales the oxygen and anesthetic. Now they're going to exhale CO2. So CO2's got to go. CO2 is going to come back through this Y, and it's going to go out through the exhalation tube to the exhalation valve. When an animal exhales, the exhalation valve opens. When an animal inhales, exhalation closes and inhalation opens. These are called unidirectional valves. They keep the gases flowing in one direction. So if it's functioning properly, when they inhale, they shouldn't be able to re-inhale through this tube because that should be closed. Okay, inhale, exhale. When they exhale, then there's this little canister that's got the white gravel looking stuff, which is your soda lime. The exhale gases are going to go through. The soda lime is going to capture the CO2. So it's going to absorb the CO2. Any leftover oxygen, leftover inhalant are going to pass through the soda lime. The soda lime only absorbs CO2. Then it's going to go through a little pressure manometer that tells you how deep your patient is breathing. Okay. After the pressure manometer, it's going to go, there's two ways it can go. You're going to have a little bag here, okay? And then you're going to have a little pop-off valve here. The pop-off valve is always going to be open. So some of your exhale gases go back in this bag and your animal can reuse it. Some of it is going to go out to scavenge. If you guys have seen, there's like a blue hose that goes up to the ceiling. We have a suction system. It's called an active scavenge. So it's every time an animal exhales, it goes out that little scavenge tube and it can leave. And then it's just going to keep repeating itself. It's going to keep repeating itself. So to review, oxygen goes through these gauges. Flow meter goes through the vaporizer, picks up inhalant. Fresh gas inlet through the inhalation valve. The animal inhales. The animal exhales through the exhalation tube. It has to go out the exhalation valve. Passes through the soda lime, through the pressure manometer, and then some will go to the bag and some goes out to scavenge. Now, one of the things I told you, to monitor respirations in your patient, you can watch that bag because every time the animal inhales and exhales, when they inhale, the bag goes down. When they exhale, the bag expands. So that's a way. So the animal is always going to get fresh inhalant and oxygen through here because it's constantly running. But when they inhale, they're also going to take some from the bag. So what the patient gets is a mixture of fresh gas and recycled gases. There is a reason this system is called a rebreathing circuit, because in this circuit, a patient can rebreathe their gases. But that is dependent on having good soda lime. Those little granules have to be fresh because if they were expired, then what could happen is they exhale, they don't absorb the CO2. The patient could re-inhale CO2. I don't know if you guys remember the other night I said I was called in on that surgery and my patient had a very high, the CO2s were in the 70s. We were ventilating. We were having a heck of a time. One of the first things I looked at was I said, when did anybody change the soda lime? Now it had been changed the week before. So I'm like, okay, it's probably not a soda lime problem. But if I have a CO2 problem on a patient, one of the first things I want to do is check my soda lime. Because some people just forget to change this. And if it's expired, it doesn't work. What is the advantage of a breathing circuit? Well, the breathing circuit is based on weight. The advantage of a rebreathing circuit is you can use lower oxygen flow a little bit, and you can recycle gases. When you use a non-rebreathing system, which is up here, you don't use the soda lime. That's why it's called a non-rebreathing. If you can burn that into your brain, because I have students that sometimes are like, well, we don't know the difference between this and this. I'm like, it's in the name. A rebreathing system, the patient is rebreathing exhaled gases. Therefore, you need soda lime. A non-rebreathing system is used for like patients that are 15 pounds and under. And so they're used on little patients. So what happens is you don't have soda lime. You can't You hook it up a different way. The way that you get away with no soda-lime is you run a higher oxygen flow. That pushes the CO2 out the scavenge, but you use more oxygen, which means you use more inhalant, and the patient gets colder. So when I get into the breathing systems and when I get into the canine lecture, I'll get into the breathing versus non-rebreathing system more. So right now, Michaela, I'm not getting hugely into the advantage, but I want you to know in a rebreathing system, you have to have soda-lime and it has to be fresh. My friend is, it reuses anesthetic gas and reduces O2 use, yes. You can run a slightly lower, and I'm not talking a big difference, but you can run a slightly lower oxygen flow on a rebreathing system. Rebreathing systems, I will just type this here real quick. Let me get my arrow. That's the nuts and bolts of it. Okay, so now before one of you can ask me this question, what do I do if I have a patient that's 15 pounds? It goes back to how much do they weigh? How well do they breathe? The first night I got called in on call, it was like 3 weeks ago. We had a foreign body and it was this 18-pound, well, they called it a chihuahua. I was like, that's the weirdest looking chihuahua I've ever seen. That's some puggle chihuahua thing. But he was a little overweight. He was portly. His belly was kind of swollen. And I knew he wasn't going to breathe well. I'm like, I know you guys. You are not going to breathe for me. Now, he's 18 pounds. By number, he would be a rebreathing system. But I looked at his weight. I looked at his chest. I looked at how he was breathing. And I was like, I put him on a non-rebreather because he was overweight and he had a swollen belly. He breathed like crap for me for surgery. But the non-rebreather, I knew if he's overweight, he has the lungs of probably a 14, 13-pound dog trapped in an 18-pound body. Am I making sense? So sometimes number will put you in one category, but it takes a little bit of analysis. You can always switch breathing systems during the procedure. If you put them on a rebreather, say you just saw the number and said, you're 18, you're this. If you put him on a rebreather and he started having trouble breathing, I would switch him to a non-rebreather in the middle of the surgery. You can do that. So sometimes a non-rebreather is just going to help the patient breathe a little bit easier. And yeah, well, I knew based on his body type and his weight, I had a vibe. And even the tech, she goes, well, you called that like out in the prep room. I said, I called that when you sent me a picture of my patient. I said, text me a picture of my patient that I'm getting called in for. And as soon as I looked at the dog, I was like, you are going to be a breathing nightmare for me. And sure enough, it was. So I went with the non-rebreather because I knew the dog presented breathing challenges. And I thought, I'm going to use the easier system. So again, I want you to know, so what I did was, the rest of this PowerPoint, I know I spent a lot of time on this slide, but I've explained a lot so I can get through the parts. There's a lot of slides in this PowerPoint. I don't want you to panic that I'm going to skip over. There's a lot of pictures. There's some slides that I'm like, for this test, so don't worry about it. We're going to get through it. But hopefully now that I've explained this picture and I've explained the order, all I want you to do for that homework question is to take, oxygen tank, arrow, tank pressure gauge, arrow, pressure reducing valve, arrow. The next part. I was up at 4 a.m. I had to get my daughter. We had to leave at 5:30 to take her to the airport. I think I'm starting to crash, so I'm trying to like wake myself up here. But you see what I'm saying? Pretend that all those parts are like parts to the heart. And all I'm wanting you to do is write part arrow, part arrow, part arrow, part. And like, oh, the other thing, let me mention one thing really quick. Do you see, remember I said we just went straight to the flow meter? Do you see this little like arrow going down? There is at the back of the oxygen tank, at the back of the oxygen line, when it comes into the machine, it splits. Oxygen is going to go to the flow meter, but then there's going to be a separate oxygen that goes behind the vaporizer, and it is called the oxygen flush valve. If in an emergency, your patient was to need fresh oxygen, if you hit that button, it'll blast oxygen into the breathing system without anesthetic because it goes behind the vaporizer. So like I use the flush valve when I check the machine because I can fill up the machine. I can fill up the system quickly with a flush valve. I use a flush valve when I want to wake my patient up because what it does is if you keep hitting the flush valve, it's going to put in fresh oxygen without anesthetic. So it's going to dilute out your anesthetic. What I absolutely do not do, and I see people do this and you're shooting yourself in the foot. I have a patient that's light and he's huffing and he's puffing and he's like the bag is going flat because he's like, huh, 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 and you need to bag the patient. And people sit there and hit the flush valve to bag the patient. Well, you know what you're doing? You are filling your bag with pure oxygen. Every time you hit that flush valve, you're diluting out your anesthetic. While you're trying to get your patient to go to sleep, you're filling it with oxygen. You're waking them up. So what you do in that situation is I crank up my flow meter, and that will fill your bag and it'll fill your system with oxygen and anesthetic to bag your patient. So I do not use a flush valve when my patient is light to fill my bag rapidly. The only time is to check the machine, to wake the patient up, or during CPR. And you absolutely never use it with a non-rebreathing system because you could blow up a cat's lungs. And I will talk about that when I get to the flush valve. Okay? Any questions? All the questions. Okay, well, looking at this schematic, you have the video of the guy going through the machine and he goes through every part and the purpose. You really need to watch that video. It's going to help you. Trust me. I'm going to lecture on these parts tomorrow. If you have any questions, I'm still entering grades. So I had a few people email me about entering the drug project, which I still need to. I mean, I've gotten everybody's emails. Yes, I did. I'm not sure why you sent me 3, Caitlin, but yes, I got all 3. Are they 3 separate documents? I did get 3 emails. Oh, I thought you just accidentally sent it 3 times. Yes, I got them. I'm hoping to go through that today. There may be a short nap here in my future, though, because I got like 3 hours sleep. I will get stuff done. All right. Yeah, I need the nap. Bad. All right, I will try to look at stuff. I'll get this converted and send out to you. I'll take a nap. I like that TikTok. It was a nap. It was a very good nap. I took a nap. Okay, I'm gonna stop being dorky. That's when my kids look at me and start rolling their eyes. But there's that one. TikTok is hilarious. So funny. So addicting. I gotta like turn it off because I'm like, one more video, one more. Yeah, it's great. I love it. But golly. But that nap one cracked. They had one with a dachshund. It was a dachshund puppy, and it was like they kept showing the dachshund puppy. I took a nap, and then he's sleeping here, and he's sleeping here, and he's sleeping here. Yes. Yeah. I've been able Oh, yeah, no, my believe it or not, this was so funny. My husband was so on TikTok like a while ago. Like he'd come home from work and the dog would be barking and he'd be in the car and I thought he was on a work call and he's like, "Oh, I'm watching TikTok." I'm like, "You've been in the driveway for 15 minutes. What are you watching?" And like forever, then he'd start to send me TikToks and I was like, "Oh, this is pretty funny." So he's like, "Download it." And then I'm sitting there on the couch going, "Oh my gosh." So like the other night, like my lovely family, all four of us, were sending TikToks to each other and we're like all in the living room. I'm like, "Oh, look at this one." My daughter's like, "Oh, mom, look at this one." Then my son sends me one. And my husband's, I'm like, "Look at us. We're all in the same room with each other." We're all just sending family bonding over TikTok where we're not speaking to each other. Oh my gosh. It's crazy.